Good morning, good afternoon, good evening, depending on where you are joining us from. My name is Musonda Lamba Millapo, and this is AMR Unplugged. Welcome back to another episode, another great conversation that we are yet to have. I have a very, I think I say that about all my guests. I say I have a very special guest, but she really is special. Her name is Dr. Kaunda Yamba. She's my colleague here at React Africa, and we'll be hearing more from her in her area of specialty. Welcome, Doc.
Thank you very much, Musonda, and hello to everyone.
Yeah. So I want to start off with on a light note before we get into the deeper stuff. In light of our conversation that we're about to have, what's the one thing that people do with medicine that makes you just want to, you know, dramatically sigh, take a pause first and sigh? What's that sort of behavior from people that makes you feel like that?
Okay. So maybe I can start by saying people is not the people on the outside, but it's all of us here, like certain things or certain behaviors that we do. So the one that makes me take a deep think or sigh is when people stop taking their medication and they feel better. Let's say they've been given a treatment for 5 days and they only take it for 3 days because they felt better, they stopped taking it. And then when someone else in the family is sick, they use the same medication to treat someone else in the family who is presenting with the similar symptoms that they had when they were unwell.
Yeah, and I can see why that would make you take a pause and have a dramatic sigh, especially the sharing of medication. So, in your practice, have you had some of those scenarios?
Yes, that is very common actually, not only from clinical practice like patients that we see, but also from some data that was collected way back where we were talking to people from the community, and they all highlighted to most of them, not all of them. Most of them highlighted to say they do share medication, especially when it's in the night, they don't want to go to the healthcare facility. They would rather start treating, let's say, a child or a spouse who's sick at home before they actually go to the hospital.
Wow. And I think that brings us to what we're discussing, stewardship. So, how would you describe stewardship? Because we've given a good example in explanation to what you've talked about in a sense, I think. But yeah, maybe you can shed more light and pack what we're about to start discussing. What is stewardship from the perspective of the healthcare facility, but also at a community level? Would you give an explanation to that?
So stewardship is something that you do to preserve something that is valuable. So in terms of like looking at the topic that we're discussing, we're talking about antimicrobials. So it's where you're preserving those antimicrobials for future use. So it's not only antimicrobials. I think it can be used in different spheres of life where stewardship is where you're taking care of something so that it lasts longer. You continue using it and also you can use it in the future generations.
What would you say, from your experience, are some of the most common misuses of antibiotics in the facility and also in the homes?
Okay. Thank you for that, Musonda. So I think before we talk about misuse and overuse, we need to understand to say there's always a reason for a behavior. There's always a driver behind why there's that misuse. So I'll start with the healthcare facility. The first one I can think of, like from practice, is not having a functional laboratory that will give you results in very good time. So with that, you find that the clinicians are treating blindly. And usually they're supposed to, maybe let me not use the word blindly, it's treating based on the previous patterns. And when you have a functional lab, you're supposed to review that medication by day 2 or day 3. But in most of our facilities, you find that we don't have those rapid diagnostics or the results will take longer. So you find that clinicians are not able to either order those tests, or if they order those tests, they don't come in good enough time for them to actually change or alter the treatment for the patient. And that's the misuse that comes about because you find that the patient is on that medication for a longer time than they should be. And in terms of the community, I think we already touched on that. That's where patients or people in the community are sharing their medication. They're not finishing their courses and they don't even seek healthcare expertise. They just go to a pharmacy and buy that medication. And most times you find that they buy that medication maybe just for 2 courses, like 2 days instead of for the 5 days, because maybe that's what they can afford. So those are some of the drivers and the reasons of misuse.
Just double clicking on your last point. I've heard this a lot, especially in the communities when we have gone out to do some community engagement where people buy half courses. Is that actually real? Does that really happen that people, because they can't afford, is that even legal?
Yes. So it's not legal,
Yeah.
but I think most people, like if you look at the human aspect of things, when, let me say, a mother has a sick child, they feel, I would rather give this child medication for 1 or 2 days while I look for money elsewhere. But you find that when the child is better by day 2, they just don't go back and complete that treatment. Yeah.
Wow. Yeah. Challenging. Now I'm thinking from the perspective of not just in the facility but also in our communities. One of the reasons why people then are misusing or overusing these precious medicines, the antibiotics, antimicrobials, is because they are exposed to the diseases, and so I'm thinking from the perspective of infection prevention and control. AMS, antimicrobial stewardship, and IPC, which is infection prevention and control. They are very closely linked. So I want to find out how poor infection prevention and control contribute to antimicrobial resistance in healthcare facilities and also in the communities. Yeah.
So when it comes to IPC, which is infection prevention and control, we can think about it in 2 ways. Or maybe I'll give 2 examples. We have the first part, which is vaccination. We know that when you have a vaccinated population, they will not easily get sick, meaning they will not have infections frequently and they will not have to take those antibiotics. And remember, we talked about behaviors. Not everyone that is put on antibiotics will finish their course. So they will not have to go through that cycle of being sick, taking medication, or misusing the medication when they feel better. That will limit the antimicrobial use as well as the development of resistance. Similarly, I'll also mention WASH, right? Water, sanitation, and hygiene. So that is a very important component of IPC. And it's not only important in the community, but both in the healthcare facilities as well as in the communities. If we have infrastructures that are providing proper running water, we know that they won't be passing on of infections or bacteria from patient to patient. Similarly, in the community, you know that if you have safe drinking water, they will not have diseases like diarrheal diseases, which result in patients either getting medication from the counter and not finishing their courses. So basically, if you have IPC measures in place, vaccination, water, you educate your community on hygiene, you won't have to use, they won't get sick and they won't have to use the antimicrobials.
Yeah, thank you so much for that good answer. You are painting a good picture, especially from the community perspective. And with AMR, one of our challenges in communicating it is that it doesn't have a face. It's really difficult to talk about AMR because they first of all, can't even pronounce the word. It's really difficult. So in your practice and in your experience, can you share real life examples of where antimicrobial stewardship helped to improve a patient outcome?
Okay. I think I'll just circle that back to a discussion I had with one of the infectious diseases doctors at the Children's Hospital here. And that was just yesterday. So he was telling me about a child that has been admitted for about 5 days. And when they got their lab results, they found that the bacteria that was causing the infection was could not respond to any of the medications that we
Wow.
have. Even the last resort treatment plan we have was resistant. So what they had to do was actually to isolate that patient, which is part of IPC. They put that patient in a different ward. They ensured the ward was clean and that it was conducive for the patient to recover from there. They also limited the visitations of bedsiders or relatives because that's another way where infections are spread. So they limited the entry of visitors coming through. They changed all the cannulas and the equipment that we're using on that patient. And all they did was just increase the dosage for the antibiotic that the patient was on. And in 2 days' time, he informed me that the patient was actually doing well.
Oh, wow.
So that's a classical example of how IPC does work, and it's a good component to AMS.
Yeah, kudos to the team that were able to put that under control. In the community is really the rich stories like that, rich examples like that could really help to push the agenda of antimicrobial resistance even further. Um, I'm looking at my next question here, and I'm taken back to a time when we were doing some community engagement in Matera. I think that must have been 2024, where one of the participants in the focus group discussion, we were basically talking about the usage of antibiotics and whatnot. And they were saying they went to the hospital, and then I think they didn't get any prescription. And they were asking the doctor, you're not giving me any drugs, because they are so used to, when you leave the hospital, you are living with some azithromycin, or, the ones that you can easily get, even though they are not supposed to be, easily accessible. So the question here would just be that, many people expect to receive antibiotics when they visit the facility. But how can healthcare workers balance the patient expectations with and also responsible prescribing? I can imagine that it can be tricky, that here is the patient telling you, I need the medication because I'm sick. So how can that balance be arrived at?
Maybe before I respond to that, I'll just give you an example of when I was still in practice. So there's a time I was working at, I think now they are first level hospitals, and there were two of us doctors who were seeing like outpatients. So most of them, you find that they're in the corridors and they'll be talking amongst themselves. So even as you're seeing a patient, you can hear them talking. So it brings me back to the issue of doctors that prescribe antimicrobials or antibiotics and those that don't. So you find them telling each other when they're sitting outside, say, don't see the female doctor because they won't give you any antibiotic. They'll just give you a painkiller and it's not enough. And that word actually goes around. When they come, they'll say, who's working today? If they find it's the person who they feel does not give them what they want, they will not want to be seen. But anyway, to respond to that question, I think I'll give an example of maternal health. Like when mothers are pregnant, there's a lot of sensitization that goes on. And it goes on in all the different healthcare facilities. They teach the mothers on different ways of how to protect themselves. If they feel ill, they should come to the hospital. So the mothers are well equipped. So similarly, I feel giving the patients enough information that they will understand to say, it's not every time I have a headache or I'm coughing that I'll need an antibiotic at this particular time. So basically education and feeding them with the knowledge that they need. One other thing is I like having these rapid diagnostic tests, because when you have those rapid diagnostic tests, you can tell to say this is actually a viral or a bacterial infection and you don't need an antibiotic. So that way you can educate the patient and tell them, see, we've done these tests and these are your results. You don't need, you'll be better. You just need to take a painkiller or some multivitamins and things like that. So yes, so it's education and also having rapid diagnostic services in the facilities.
Yeah, I've heard that comment before. You're right, in the sense that I think even from my family, I've heard people saying, well, they just gave me Panadol, and they really believe, they are really convicted that they should have walked away with an antibiotic. Yeah, so you answered the question so well and already framed the next question that I had, which is really that what role do community members play in protecting these antibiotics? I think you answered it from the clinician's perspective, that maybe, bringing in the rapid diagnostics and whatnot, but the community themselves, what role can they play?
Okay. Maybe we can ask a question again.
Yeah.
Who is the community?
Exactly. Who is the community?
Who is the
Go
community?
ahead, please, Doc.
Yeah, so the community is all of us.
Yeah.
We all belong to a community. We belong to a family. Like we all play a role in ensuring that antibiotics are preserved. So what can communities do? I think I touched on this earlier. Like those that are having young children, is to ensure that their children are vaccinated. That way they prevent them from getting infections and they won't need the antibiotics. You preserve antibiotics in that way. Secondly is to seek medical care. Like they should not just go to a pharmacy and get whatever medication they want, but they should make sure that they go to the hospital, tests are done, and they're given medication that they need at that particular time. The other one, I think, is just to ensure that there's good behavior in case of hygiene. Like they make sure they wash their hands when they use the toilet, they wash their hands before they eat food. So it's just those behaviors that they can keep teaching each other and teach children as they are coming along.
Yeah, behavior change is difficult, but it's possible. So I'm glad that you touched on that. I can imagine that stewardship, as important as it is, because you have really, underscored the importance of antimicrobial stewardship. I can imagine that it comes with its own set of challenges. So I would want to find out what are some of these challenges, especially from the facility point of view, in light of the limited resources that we have as LMICs here in Africa.
Since you've talked about resource limited settings,
That's one of them already. I've answered the
yeah, so
question for you.
the first response would be finances. Like
Yeah.
maybe we don't have enough finances, but I think we need to move away from that, even if that's the fact of the matter. But we need to know to say there are also other interventions that we can put in place that don't require enough, like that don't require finances or
Yeah.
a lot of money to go into it. I'll give an example of just practice in a healthcare facility. There are things like having patients, like collecting a sample that will help you determine whether the patient, what type of bag a patient has. You collect those before you start your antibiotics. I think that's a practice that doesn't need funding. Reviewing a patient at 48 to 72 hours, that doesn't need funding.
Yeah.
You just need to have that behavior to say, this is what I need to do. And when I'm seeing a patient, I need to review. But coming to the resources, I think the biggest challenge when it comes to LMICs is the lack of diagnostics. Because for diagnostics, you need a lot of money, especially for microbiology. You need a lot of money to have a fully functional microbiology lab that will provide you with results in good enough time for you to actually manage a patient effectively and also rationally use your antibiotics. So I think that's the one I can refer to as resource limited countries is the issue of diagnostics.
Yeah, well put. To every challenge, I guess there's an innovation. And as Africans, we are very skilled in finding solutions. A lot of challenges have birthed also great innovations. So I'm wondering, are there such innovations in antimicrobial stewardship, especially again from the health facility setup? What sort of innovative initiatives, should I say, have come up, or yeah, what things have helped to address the challenges that you have highlighted? Yeah.
Okay, so I think we can't go, when you talk about innovation these days, you can't go away from artificial intelligence, which is AI.
Yeah.
And you find that a lot of people think that AI is the magic or the solution to every problem. But what we must understand is that we need to generate quality data or quality information and feed the AI for it to give us what we really need for managing our patients. So, giving examples of the different innovations that are in the healthcare facilities, I'll talk about where the AI has been fed with the hospital's treatment guidelines, and the clinicians can actually just at the tap of a button, like just use their phone to check which treatment a patient is on, what the duration should be, what the dosage should be. So there are different types. You can have your treatment guidelines on the AI. You can have AI that's helping you with rapid diagnostics, where you feed in the results that you've gotten and it will give you the results instantly. And also you can have platforms where it's helping you educate the community as well. Yeah. So those are the ones I can think of.
And as here we at React Africa, are there any that you'd like to highlight that are similar to what you have spoken of?
Yes. So here at React Africa, when we talk about antimicrobial stewardship, there's a project that is going on called Aspire, where we are using innovative tools. So as I spoke about, there's the digital tool, which is helping with collecting patient data. And also as you enter your clinical, how the patient is presenting, You can click a button and it will tell you the type of treatment you can use and also what the duration is, what to look out for, what side effects are there. Then we also have what we call a chatbot, which is being used also by both clinicians and the community. So for the community, it's just educating on the side effects, how to manage your side effects, when to stop taking your medication, when to consult a clinician if you're experiencing any side effects that you're not sure of. Then on the clinician's part, it's helping them with also the same management of patients. So I should mention, I think I talked about data. This chatbot has been fed with the treatment guidelines for the facilities that we are working with. So you can't say it's just AI or the way Google is where you just
Yeah.
put in and search. This is where it has been fed with the treatment guidelines from that particular
They are
facility.
facility specific. Yeah, okay,
Yes,
that's
thank
good
you.
and innovative. I'll sound biased if I keep saying that it's great. It's a
Yeah.
great innovation. It is, but because I'm also from React, I'll sound biased. So thank you for that response. You talked a lot on behavior change, both for clinicians and also people in the community. And this is an area that is close to my heart, education and awareness, antimicrobial resistance education and awareness. So how do you think campaigns on bordering on education can change behaviors around antibiotic use in communities? What strategies do you think can actually work?
Um, so when we come to education and awareness, we need to understand the group that we are working with. I think that's why it's always important to first go in, speak. If you're dealing with healthcare professionals, you go in and you assess what their knowledge is, what influences their attitude and their practice. Similarly, for the community, you also go in and check what the levels of knowledge are and what would really help them understand what antibiotics are and how they can preserve them. So that way, you come up with a tailored approach of education, because what you're using in a healthcare facility is not what you use in the community. It must be specific to that particular group, and you must ensure that they're able to grasp and have the knowledge that will help them preserve these antibiotics. So similarly, there's that project that you're working on with the kids, and you've come up with creative ways in which the kids can understand what antibiotics are, how misuse will, limit the future options. So it must be tailored specifically to the group that you're targeting. And the other way is also using influential people in the community. Yeah, especially in rural areas, you can use the chiefs, the headmen. In both rural and urban areas, you can use the faith-based approach where you have the pastors or priests preaching on it or just educating them. So you can educate a group that is influential, and those are the ones that will now relay that message to the community. I think those are the approaches that I've
Yeah.
found work.
Yeah, I think they work too, especially what we've been learning with engaging the children is really not dumbing down, but simplifying the message of antimicrobial resistance to that particular audience. And so, yeah, I think those approaches are really good. And just to wrap up our conversation, Doc, thank you for all the answers you've been able to give and the insight you've given and just the conversation that we've had. But a world where antimicrobial resistance continues to rise, what could healthcare and everyday life look like? I want to hear from you.
Okay, so before I dive into that,
Yes.
maybe let me unpack the word antimicrobials.
Yes.
So antimicrobials are not only the antibiotics, right? The commonly known Flagyl, Septrin. Those antibiotics fall under the umbrella antimicrobials. We also have antivirals, like the medication that is used to treat HIV patients or to manage HIV patients. We also have antiparasitics, like the ones that are used to treat malaria. So it's a broad term. So why I'm giving that example is because I want us to understand, like those of us that have lived long enough or practiced in the time when HIV was rampant and there were no ARVs. So during that time, the hospitals were always packed. So you find the hospitals are overcrowded. Patients are staying in hospital for a longer period of time. There were a lot of deaths and mortalities that could have been avoided. So that example is what antimicrobial resistance will end up being. We'll have these medications, but if they're not working, patients will be in hospitals longer. And if we have overcrowded hospitals, we know that they'll be passing on infections from patient to patient. There's what we call hospital-acquired infections. Yeah. And usually those are caused by notorious bugs that are not easily treatable. Then you also find that the complications that come up with those overstay or long stays in hospitals will complicate the management of these patients. Yeah. So it's not something that's a good thing. And if we did understand or we looked back at what HIV was without the antivirals, then we'd be able to actually know how serious this issue is.
Yeah, indeed, it's serious. And on a light note, you said the notorious bugs. And in my mind, I don't know, do you know Notorious B.I.G.?
Yes, I
So the
do.
moment you said notorious bugs, I just thought Notorious B.I.G. Maybe we should have an awareness campaign that links BIG to. Yeah, I kept thinking that. So thank you so much, Doc, for the insight that you've given. I've learned a lot. I was thinking the one thing that I feel like I shouldn't end the conversation without clarifying, in case there's someone else like me who was stuck on rapid diagnostics. What's that? Quickly.
Okay, so rapid diagnostics are tests where you get the result there and then. You don't have to go home and come back the next day. You can get the result. It depends on the type of test. So let me say in an hour, 2 hours, the results will be ready and you can be managed based on those results.
Thank you. Just clarifying for me and the person who was still thinking what is a rapid diagnostic. Thank you so much for watching up to the end. Be sure to follow us on our social media. That's React Africa on all social media platforms, RunTube on YouTube. Thanks for watching.